Hi, and welcome to the How to Survive Healthcare podcast. I'm your host, Kayla Thompson-Riviere, seasoned critical care RN turned independent patient advocate. Tune in every week so that you can learn the things about the U.S. healthcare system that no one ever tells you. That way that you can get the most from it and optimize your health outcomes. Now, of course, this podcast is strictly to inform and entertain and should never be taken as a substitute for medical advice. Let's dive right in. Hey guys, welcome back to the podcast. Today's episode is going to be a little bit different than our typical format. So, as you may know, I was a guest speaker on a national patient safety webinar last week. The organization is called Pulse, and they work in conjunction with People for Patient Safety. By the way, they do a educational webinar for people just like yourself, patients and caregivers, every second Monday at 7 p.m. It's a Zoom meeting. So I was a guest speaker this past week, and I covered the critical role of family in hospital safety. And that presentation was so well received that I decided, you know what? I'm going to bring it here to the podcast for everybody who wasn't able to attend. The webinar was recorded, but the people on the webinar were obviously engaged in watching the screen, and I know a lot of people listen to this podcast, so for that reason I felt like I wanted to just approach it a little bit differently, so that if you're only listening and you don't have the visuals, I wanted to still make sense to you. So that's the reason for the separate recording. Plus, when I was on the webinar, I didn't realize there was going to be such a tight speaking timeline. And unfortunately, I wasn't able to finish my presentation. The last slide I wasn't able to deliver. So if you watched the webinar and you were wondering how it was supposed to end, fear not, now you will see. So without any further ado, let's dive right into the critical role of family in hospital safety. This nice little visual for those of you who are watching. There's a family pushing their family member, presumably out of the hospital at discharge in a wheelchair, which is, of course, the goal. We want to make sure that nothing unfortunate happens to our family member during their hospital stay. So the goal of this presentation is to equip family members with practical tools and resources to protect their loved ones during hospital stays. If you've been around for a little bit, you know that I give a lot of information in these podcasts. This particular episode is no different from that. In fact, it might be a little bit more information than you typically get. If you are a caregiver who has a loved one who is maybe in and out of the hospital, or you think there could be a hospitalization on the horizon, I would encourage you to take notes, or at least download this episode so you can come back to it for future reference. So I start off with, what is advocacy? And I think I've talked about this before on the podcast, but in case you're new here, the core principle of advocacy is to be the voice for the voiceless. Now, when I say that, some obvious things might come to mind. Like, for instance, if you have a loved one who is maybe confused, disoriented, maybe they have dementia or something, and they can't really speak on their own behalf. Or another thing that comes to mind is in and around surgery, where somebody has medications and they can't really speak for themselves. On that note, also, if they're in ICU and on life support equipment and they're really in a position where they can't speak for themselves. But I want you to actually kind of broaden what we're thinking about here, because it's not just when people are literally voiceless, okay? Anytime anybody is interacting with the healthcare system, whether that be your loved one or even yourself, you're put into a position where as soon as you're a patient, you're in a stance of disempowerment. So if you think about going into the hospital, you oftentimes you have to strip down to a hospital gown. So you're naked and laying in a bed, and all of these people with lots of education and degrees come in around you and are telling you, what to do and how it's going to go. That's a very disempowering position to be in. And for that reason, even if you physically have a voice, you should have somebody with you to help advocate on your behalf, whether that be a spouse, partner, family member, best friend, or a professional patient advocate. Because simply being a patient makes it difficult to advocate. Advocacy in the realm of healthcare is best performed by two people at all times. So that's my spiel on advocacy. However, it's even more important when we're talking about a hospital setting, because when people are admitted to the hospital for a variety of reasons. But when you boil it down, if you or your loved one is in the hospital, they're not feeling their best. You're sick or injured. You're not thinking as clearly as you normally would. And that's even before we give you medications, that can kind of interfere with all of that. So family caregivers actually play a crucial role in ensuring that that patient is receiving proper care. And you're going to do this through asking questions, tracking care, and speaking up whenever something feels wrong. I just want to really emphasize, trust that gut feeling. That gut feeling of something being wrong or off. It's oftentimes we discount and its validity. However, research has shown that it really stems from this portion of our brain that stores memories, but not with language. So when you get a gut feeling that something is wrong, it's not, even though you can't articulate why, doesn't mean that it's not correct. And really what it is, it's the culmination of things that your brain is remembering similar events before and throwing up red flags, and you just can't pinpoint why. But that doesn't mean that it shouldn't be trusted. I like to say, the doctors are fantastic and they do have years of education and experience on a medical topic, but you are the expert of your own body. Nobody knows your body than yourself. So when something is off, you have to trust that. And don't be quiet about it. So I want to go over a few alarming statistics and start to help you understand why family involvement matters, particularly in the case of hospitalization. So 1 in 10 patients experiences a preventable error during their hospitalization. And furthermore, nearly half of all patients experience some kind of a negative consequence that is actually unrelated to why they're in the hospital, but is from the hospitalization itself. Now, family advocacy can reduce errors by up to 30%, mostly in the areas of communication breakdown and falls or physical safety of the patient. So even though you may not have a degree or a healthcare background, you absolutely make a difference in the care of your loved one while they're in the hospital. So I want to kind of go over a little bit of the hospital environment with you to help you to understand why it's such a high-risk place. Hospitals are very busy, high-pressure environments, and particularly since the COVID pandemic, we have really seen an increase in patient acuity, which is how sick people are, and a decrease in staffing. The number of doctors, nurses, and other support staff that's available to care for those really sick patients. In addition to that, hospitals are largely run with one-size-fits-all protocols. So for instance, if your loved one has a diagnosis of heart failure, they'll be admitted, and all of this treatment plan will be generated under this protocol of heart failure. And the doctors get to look at all of these check boxes and check which ones do and don't apply. And I've talked about protocols before. They have risks and benefits to them, but the highlight is that if your loved one has any needs that fall outside of that protocol, it's a very high risk that they may get forgotten. In addition to the protocols and the staffing issues, you have a lot of turnover of the care team. For the most part, the nurses are working 12-hour shifts. Not only is that a long shift and puts that nurse at risk of being kind of tired and burnt out at the end of the day, but you also twice a day are having a new set of eyes taking care of your loved one. Now, sometimes the nurses work some back-to-back shifts and there can be some continuity there, but you can't count on that. Furthermore, your physicians are typically on 1 week at a time. So if you're admitted towards the end of that week, which may or may not run Sunday to Saturday, you could be looking at a whole new team of medical staff throughout throughout the hospital stay. Every time that there is handoff or turnover from provider to provider, you run the risk of losing vital information about the case. And it takes time for that new provider to either notice the pieces that are missing, or to dig it up in the chart somewhere. And so for all of those reasons, that they can create a lot of communication gaps with this turnover. Some of the risks associated with this busy hospital environment are medication errors, overlooked symptoms, again, the communication gaps, and also sanitation. Often I've seen it myself, how many times the care staff is just running around like their hair is on fire and in and out of the rooms, and just trying to get things done to take care of their patients. And obviously medications are a priority with what's being given, but what isn't a priority? Following proper sanitation protocols and isolation protocols. So what does that mean? Everybody has germs on them all of the time. They're all over your skin. There's nothing you can do about it. It's completely normal. However, there are some germs, we call them superbugs, which, by the way, if you're interested, I've done a podcast episode on that before. Go back quite a few. But the issue with superbugs, in a nutshell, is that they spread very easily and they're very difficult to kill. They thrive in healthcare environments, so much so that when somebody gets an infection from some of these superbugs, they're one of the leading types of hospital or healthcare acquired infections, and it's a totally separate subset of infections because they're just so difficult to treat. But you have, at any given time, you can have multiple patients on a hospital floor that have these superbugs. And when the staff cares for those patients, they are supposed to be using various levels of PPE, personal protective equipment. So this is when you've seen staff, or maybe you've seen pictures of nurses in like gowns and gloves and face shields. It's for different types of infectious disease, so that way it doesn't and it's based on how the germ is transmitted. I will tell you, when your staff is overworked, proper PPE is one of the first things that I see the ball get dropped on. So what does that mean? It means the room that the person has, we'll use COVID for an example. When a patient has COVID, anybody who goes into the room is supposed to have a gown, gloves, an N95 type mask, and some sort of face shield or eye protection. How often, if there's any healthcare professionals listening, how often have you seen somebody, I'm just going to be real quick. It's just for this. It's just for the pump. And they go in the room with either none of those things or not all of them. And then they come back out. Well, now the problem is that germ in this example, COVID, is on the person's physical body, and now they can carry it and transmit it to the next room. We see this with equipment as well. There's equipment, again, depending on what the germ is supposed to be cleaned from patient to patient, which definitely doesn't happen. And depending on what bacteria or germ that they have, sometimes it's supposed to be the regular wipe, sometimes it's supposed to be bleach wipes. Anytime anything is wiped, it's supposed to sit for a minimum of 3 minutes, sometimes 4 minutes, depending on the product. These things are not happening, especially not when your staff is, again, overworked and just trying to get everybody their medications and keep them alive. So that's where the sanitation part of that comes in. So all of these issues in the high pressure, busy hospital environment, these are opportunities where family can absolutely be extra eyes and ears on your loved one's case, and also speak up about that sanitation. One of the easiest things is kindly reminding your healthcare providers to be using either washing hands or using the hand sanitizer coming in and out of the room, and certainly before they're touching your loved one. Also, I would encourage you, something that I see overlooked a lot on the topic of sanitation and how you can help is those bedside tables that are next to the hospital bed. Those things do not get wiped down enough. So for me, when my family's in the hospital, it's one of the first things I do is put on a pair of gloves and clean off that table, because they're eating every meal on it. And oftentimes men are putting the urinals up there. It needs to be cleaned. And then, of course, making sure that you're offering your loved one to wipe clean or use the hand sanitizer at least before they are eating meals, if they're not able to get up and wash their hands. So those are some ways that you can really help decrease the level of risk to your loved one in this hospital environment. Now, the next big piece for the family advocate is documentation. And when I say documentation, it's going to be extensive. So anything that is done or said about your loved one should go in a dedicated journal or notebook. I literally want you to be keeping track of the who, what, where, when, and why. Do you remember that from elementary school? But all of these things are going to apply to the care that your loved one is getting. And remember, we want to be documenting things before and also after they happen to your loved one. So, for example, with medications, I don't want you to write down, oh, they got an antibiotic. I want you to write down the antibiotic's name, the dose, the time, the route. That means if it was IV or a pill by mouth, the doctor that prescribed it, if you can. And then again, what happened afterwards. Note their response to it. So you're going to do this with any kind of medication, treatment, therapy, procedure, or anything else that is done with your loved one. I also want you, as I said, to be documenting things that are said in and around your loved one. So that means what the nurses are talking about during shift report, what the whole care team is talking about during rounds, which rounds, depending on the facility that you're in, can be made up of it's a collaborative care team. Sometimes it's usually the pharmacist, the case manager. They try to include the bedside nurse. And depending on the case, it can have some other people involved, but they come around and they actually are all together all at once to talk about the patient and where they're at with things, what the next steps are, what we're waiting on, etc. That can be a great time for you to either help close those gaps in communication or listen in, because sometimes you'll get pieces of information that maybe you hadn't heard before. Unfortunately, healthcare is an area where there's still a huge lack of transparency. So there's often things that are said about the patient's care, not to the patient. It drives me crazy. but that's what it is. So make sure that goes along with make sure you're asking questions and don't feel bad about asking questions. You also, of course, want to be making sure that you're taking note of the things that the doctors and specialists are saying when they come in to see your loved one. Now, for those who are watching, you'll notice that I underlined and bolded the word specialists. And that's because when someone's in the hospital, they have one doctor or sometimes nurse practitioner, but one provider who is kind of in charge of everything. And they're called a hospitalist. And they are coordinating all of the specialists throughout the hospital stay. Now, the specialists, those are the ones who are like the heart doctor or the kidney doctor. And they are looking at the patient just through the lens of their specific specialty. Not exactly always looking at the whole big picture. So what does this mean? When obviously we want specialists involved because somebody who specializes in the kidneys per se has the ability to know and do so much more about that area than the hospitalist who is a generalist. However, what I've seen time and time again is the specialist gets brought into the case, they go to the room, they see the patient, they tell the patient, and they've told me as a bedside nurse before, oh, I think we should do this, and that. And then they go and they write their note and they put it in the note, I recommend the following, da, 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 da. But then it stops there. And guys, recommendations from a specialist are not orders. So even though the specialist just came in the room and told you that your loved one needs this medication and they need to start it as soon as possible, there's a very good chance they're going to walk out of the room and not even order that medication. And so you need to be following up with the nurse and with the hospitalist and making sure that you say, hey, the specialist just was in here and said that this medication should be started. Is that ordered yet? Are we still going to do that? Because I can't tell you how many times I have gone into a patient's chart as the nurse and looked at the specialist note that they wanted to start a medication that they then never ordered. And I called the hospitalist and like, hey, the specialist recommended this med 2 days ago and we didn't give it. Oh, well, the hospitalists didn't know because they thought that it was getting ordered. So that's a huge area where things get missed. So know that and be on top of that. So the next slide here is a little bit technical. This is, I would call this extra credit here if you're following along this whole presentation. So I really just wanted to, it's called ADPI, and it's the 5 stages of the nursing process. Now, this is a structure and a format that I use when in guiding my care with my clients who I am professionally advocating for. Just because I like structure and framework to make sure I am not missing or overlooking anything. Now, this may be a little bit more than what you need to be managing your loved ones, but if you're somebody who's like, man, this is a lot of information and I'm really overwhelmed and I wish I could organize it in a way that it made more sense, ADPI may be helpful for you. So ADPI, it's an acronym and it stands for assessment, diagnosis, planning, implementation, and evaluation. Now, this particular graphic shows these things in a kind of a linear pattern, but truly, in my mind, ADPI is a circular process. So assessment, it is the first step, and we're just analyzing and collecting data about the patient. What are their biggest struggles right now? Why are they in the hospital? What are the many things that are going wrong? Step 2 is diagnosis. Now, medical diagnosis and nursing diagnosis is a little bit different in my professional practice as an advocate. I look at them both because there's a lot of interplay between the two. But when we say diagnosis, really we're putting a label on some of the problems that they are having so that we can then move on to planning. So planning, we start to figure out, okay, what are some things we can do that may help to address this problem that we diagnosed after we looked at our assessment of them. After planning, of course, comes implementation. We're going to start doing the things that we think are going to help treat this problem. Now, the last part that's so important is evaluation. Anytime we do something, we want to look afterwards and say, was it helpful? And if not, then we're going to go all the way back to the beginning and look at and assess them again and come up with, narrow down to another problem, come up with another plan, implement that plan again, and evaluate again. So this is where I said it's pretty circular. This may be definitely a little bit more high level. So if I sound like the Charlie Brown teacher, wah, 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 don't worry about it. You're fine. Just fast forward a little bit. But like I said, if you're someone who you feel like you're getting a lot of data and you wish you had a way for it to make a little bit more sense, then this may be helpful for you. Now, I have another acronym for you, but this one relates to medical decision making because oftentimes through our healthcare journey, and particularly when our loved one's in the hospital, there's probably going to be times where your providers are asking you and your family to make decisions. Sometimes they can be some really tough decisions. So often in healthcare, when you are presented with options and you're asked to make decisions, the doctor usually will share some of the risks and benefits of whatever the proposed intervention is. However, risks and benefits alone are not all the pieces that are required for good, solid, informed medical decision making. So here on this page, I've got another acronym for you. This one is BRAIN. Easy to remember because, of course, what are you using to make decisions? So risks and benefits that's usually the phrase. However, for the BRAIN acronym, we're going to turn it around and talk about benefits and risks. What are the potential benefits or the side effects that may occur with this proposed intervention? However, the next piece I want you to consider before you make any medical decision is alternatives, because this is one that we often, our providers are not always as good about remembering to discuss. And a lot of times we don't know to ask about, but always ask, are there other options available, other alternatives? There's always at least two paths, do or not do. And nobody can decide which is the right answer for the patient, except for the patient and their appointed decision makers. So always make sure that at every juncture, we are looking at the minimum two options. The next piece is intuition. Whenever you're making a medical decision, always stop and check in with your gut feeling. Because if you remember what I said to you before, that gut feeling is actually a culmination of all of your previous life experience. It's just presenting in a sense of feeling as opposed to words, because it's stored in a portion of the brain that doesn't have access to language. So check in with that gut feeling and lean into it, really listen to it and see if you can tease out where that's coming from or maybe find some words around it. The last piece of our BRAIN framework is nothing. What happens if we do nothing? Or if we delay making a decision for 20 minutes, 30 minutes a day? It's always worth asking if it's okay to pause and come back to the decision later. Now, sometimes it's not, but anytime that it is safe to delay a decision and allow for more time and room for decision making, the better of a decision that you're going to make. Decisions made under pressure, as I'm sure you know, can often backfire or turn out to be the wrong decision in hindsight. So asking for more time can help to avoid that. All right, I think that's going to be the end of the technical slides, guys. So thank you for sticking with me through that. Now, I do have some practical techniques for voicing concerns effectively, because of course we hope that the hospitalization will go off without a hitch, that all staff are going to execute their roles, perfectly, and that nothing is going to be overlooked. But we know that the reality is that probably won't be the situation. So we always want to hope for the best, but prepare for the worst. And that's really what this slide is about. So when you do have a concern that you feel you need to escalate, there's a pathway for that. Often people think that any problem needs to be dealt with the physician. And certainly there are problems that can only, it's probably less than you would think. So when you have a concern, start with addressing your bedside nurse, the nurse who's actually coming in the room and taking care of also called a shift supervisor sometimes, but this person is going to be in charge of all of the nurses on that unit for that time period. Above the charge nurse is the house supervisor or nursing supervisor. Again, the language can change facility to facility, but this is going to be the nurse who is in charge of all of the floors in the hospital during that shift. Again, next to or above, just depending on the issue, there is a physician. As I said, some concerns have to be addressed with the physician or someone of the medical staff only. And then if you are still unable to get your concerns voiced effectively, there is also a patient advocate or ombudsman for the hospital. And sometimes you need to reach out to them as well. Although typically, in my experience, if it has to go to that point, we are looking at a challenging situation. So I hope that that's not where you have to go. Now, whenever you are trying to get your concerns addressed, of course, we know that the way in which we approach communication actually tends to carry more importance than what the way we say something means more than what we are saying. So we have to make sure that, especially when we're coming with concerns, it can be very easily interpreted as criticisms. So we want to make sure that we are remaining calm, cool, and collected. Think about what you're going to say before you have the interaction, and make sure that you're taking nice, calming, deep breaths prior to. I get it. When it's your family member, your loved one, and you're having to address something that isn't right with their care, it is really easy for emotions to get pulled into that. And honestly, the experience I've had with myself in that situation is part of the reason why I started my independent patient advocacy practice, because having that neutral third party to be able to handle and mitigate some of these things can be, it can just make all of the difference both in getting your concerns heard and for you not having to have the stress of that confrontation. But when you are approaching your care team about concerns with care, you also want to follow the cuss technique, which is ironic. Don't cuss at your care team, but it stands for C, U, and S. You want to focus on using words around being concerned, uncomfortable, and wanting to maintain safety. those words, incorporating those words into what you're saying is going to make sure that your care team is hearing that you are concerned and not that you are criticizing. You also, as much as you can, want to point to tangible signs as opposed to emotions or feelings. And now you may be like, wait a minute, Kayla, you just said to lean into the emotional part of my brain. And that's true. For your gut feeling is going to notice that, pick up on that red flag before your rational, logical brain is going to. However, for that to translate into being something that another person can understand and see why they need to take some sort of action, we do have to put language to it. So for instance, instead of, hey, you're not taking care of my dad's pain properly, it would be more effective if you said something along the lines of, hey, I have noticed that he is having some facial grimacing and grunting, and I'm concerned that he may be uncomfortable. Is there something more that we are able to do about his pain? Same exact concept that you're trying to share, but it's going to be received completely differently. Anytime that you are bringing up a concern, if you remember a few slides back, we're going to document everything that is said in and about the patient. So any concern, document it, both what you said, what the staff member said back to you, and what the outcome of that conversation was. Now, as you go through the hospital stay, some people are surprised by this, but the staff actually starts planning for discharge when the patient is admitted to the hospital. And it's not to boot out the patient as soon as possible. It's just truly discharge is quite a process. And if you wait until the person is ready to leave, if you wait to start planning this, then it's going to cause a huge delay. And I think the majority of people really don't want to be in the hospital any longer than you need to be. And then, of course, certainly the insurance doesn't want to pay for it any longer than it's required as well. So for those, it's a logistical reasons. Discharge planning starts at admission. That being said, though, there has certainly been many times I've been involved where it does certainly seem like the hospital is just trying to boot somebody out, perhaps before they're ready or without an appropriate plan in place. So we want to make sure that we're protecting our loved from the beginning, you should be as well. There are situations where it's clear from the beginning that your loved one is not going to be able to go back home. For instance, with my grandmother's had a few hospital stays this year, and we know from the time she goes in the hospital, she is going to need to go to short-term rehab and get some strength back because she loses it so quickly. So if that sounds familiar to you, make sure that the hospital is recognizing that as well. That's one of those things. It can take several days just to find somewhere for someone to go. And then there's different certification process. So getting the ball rolling on that as soon as possible is definitely to your advantage. So know that short-term rehab is an option. This is because when you are in the bed or, just not doing your usual physical activity, especially our population that is over the age of 60 can lose muscle mass very quickly. So even if your loved one was just in the hospital for, I don't know, this heart failure, even if they were just in for a couple of days, they may find themselves too unsteady on their feet to be safe to go home. So know that short-term rehab is an option for just general deconditioning. When we're talking about our discharge, we also have to think about transportation and equipment. Has something changed with your loved one's condition that they now need more equipment than what they currently have at home? For instance, maybe for right now, they need a bedside commode because their bathroom is too far for them to walk to in the middle of the night. Or maybe they need a walker and they don't have one yet. don't leave the hospital until you know that you have the equipment either there or on the way. You have to think about this with transportation too. This comes up most commonly. I've seen issues with oxygen. So, for instance, maybe your loved one had that congestive heart failure admission and they're going home on 2 liters of oxygen. Well, here's what I've seen happen a few times. The oxygen concentrator in some bottles goes and gets delivered to the house. All right. But how about the ride home? I've had a couple instances in my nursing career where, oh no, we forgot about that because they can't go home with the tanks from the hospital. They need to have another kind of intermediate tank to be able to be delivered to the hospital for the ride home. Home health. Are they going to need home health? Do they need nursing care? Do they need non-medical assistance? All things to consider and make sure are in place prior to leaving the hospital. Medications. Oh man, medications at discharge is one of the biggest areas of medication errors that you need to be on the lookout for. So when you're leaving the hospital, medications can either be new, that you can have some medications that have stopped, or perhaps they have changed medications that your loved one's currently taking. All of these things you need to make sure you understand very clearly so that there aren't any medication errors. Furthermore, for medications that are new, where's the prescription? Has it been sent to the pharmacy? If it has, what pharmacy is it at? Is that pharmacy going to be open when you're leaving the hospital? Hot tip, find the nearest 24-hour pharmacy near you and consider using that for any time you go to the hospital so that no matter when you leave, you're able to get the medications. Some medications cannot be delivered electronically to the hospital. For instance, in this where I practice, narcotic prescriptions have to be a paper prescription that gets physically taken to the pharmacist. If that's the case, you're going to want to make sure that you know that and you have that before you leave the hospital. Ask for written instructions and follow-up details. Depending on when and how long you were in the hospital, your follow-up appointments may or may not have been made for you. So be very clear about that and know what appointments still need to be made and what appointments you're expected to go to. Make sure you clarify any concerns about ongoing care and don't leave until they're mitigated. Sometimes the nursing staff may be in a may seem to be on quite a time constraint to get you out once the discharge order is there, but that's okay. They work for you, you don't work for them. So don't be afraid to stand your ground and do not leave until all of these concerns are explained and addressed. The magic words around a discharge that all the right pieces aren't there is unsafe discharge. Let me tell you, no case manager or hospital administrator wants to hear the words unsafe discharge. If there is something that's not being set up right, you make sure that you voice that you are concerned that this may be an unsafe discharge for your loved one because of XYZ. They're too weak to get out of bed, don't have a walker at home, whatever the case may be. But that phrase unsafe discharge, when used appropriately, is going to be the most helpful for you for this discharge situation. So, that was a lot of information. I hope that helps to illustrate why family involvement can make such a big difference in safety. And I hope this encourages you to take a more active and proactive approach to your family members' hospitalizations moving forward. They really are counting on you because without you, all these pieces are just kind of falling to the wayside and things can slip through the gaps and a person's care can be really negatively affected by that. If this sounds like it's way too much and just totally overwhelming. Believe me, I get it. And guys, this is why I'm here. This is exactly why I started my advocacy practice. So if you are in charge of a loved one who is frequently in and out of the hospital, or has a hospitalization coming up, and this sounds like this was a lot to you, please reach out so I can see how I can help you. You can find me, of course, at heardforlife.com, but also my phone number is 443-373-1610. Reach out anytime, guys. I am here for you, and we'll get your loved one taken care of. So I hope this was helpful. This is, oh my gosh, I didn't even say it. This is actually my last episode by myself. Next week, we will be putting out a special 3-episode drop on Monday, Tuesday, and Wednesday to celebrate our relaunch of How to Survive Healthcare with my friend Nicole Broadhurst. She's going to be permanently on the show with me now. Let's stop the screen share. But yeah, Nicole is coming on. She does the insurance and billing. So she'll be bringing the financial aspect to everything to complement my clinical aspect of everything in and around healthcare. So really excited for that. So anyways, thank you guys and take care. See you next week.